Welcome to the Head and Neck Cancer 2020 video series, presented by St Vincent's Hospital Sydney, the Kinghorn Cancer Centre and St Vincent's Private Hospital Sydney. Innovations in Chemotherapy and Immunotherapy with Dr Venessa Chin and Dr Amy Prawira.
Hello, my name's Julie McCrossin, and it's my great pleasure to welcome you to this video on innovations in chemotherapy and immunotherapy. And it's part of a series of videos for head and neck cancer patients, family members and multidisciplinary team members, all about innovations in treatment to improve survival and, very importantly, quality of life. 7 years ago, I was treated for stage 4 oropharyngeal cancer. That means cancer in my tonsils, my back of my tongue and the side of my throat. And indeed, I had my chemotherapy in this building, the Kinghorn Cancer Centre. These videos are hosted by the Kinghorn Cancer Centre and St Vincent's Hospital, Sydney. So it's my great pleasure now to introduce the two doctors who are going to talk to us now about chemotherapy and immunotherapy. First of all, Amy, can you introduce yourself?
Sure. Well, thanks, Julie, for hosting this wonderful event. My name is Amy Prawira. I'm one of the medical oncologists here at the Kinghorn Cancer Centre. I specialize in looking after patients with head and neck cancer, and my other specialty is early phase clinical trials, so patients with advanced malignancy.
And we'll hear more about clinical trials later. And could you introduce yourself, Venessa?
My name's Venessa Chin. I'm also a medical oncologist here at the Kinghorn Cancer Centre and St Vincent's Hospital, and I also work at the Garvan Institute as a postdoctoral research officer, and I focus on head and neck cancers and lung cancer.
Can I ask you, let's talk about chemotherapy. What is chemotherapy? How does it work?
So chemotherapy are medications, usually given through a drip or through intravenously, but occasionally via tablets. And they're drugs that seek out cells in the body that are rapidly dividing. So cancer cells in general divide rapidly, and they are susceptible to these drugs, and these drugs cause cell death. Where we get the side effects is where the drugs are also targeting other cells in the body that are rapidly dividing, like the cells that line the bowel, your hair, the cells that line the mouth.
Okay, so that's why chemotherapy is good for killing cancer cells, but it may damage healthy cells in some parts of the body.
That's right.
I see. And what are the names of the common chemotherapy medications that are used for head and neck cancer patients?
So one of the most common drugs is called cisplatin, or a closely associated drug, carboplatin. Another drug that's commonly used is 5-fluorouracil. There's also a class of drugs called the taxanes, and also the immune therapy drugs, which I think we'll talk about a little bit later.
And how do you decide what chemotherapy medication to give to a head and neck cancer patient?
It depends what kind of treatment they're having. For example, a patient who's having combination chemotherapy and radiation, similar to you, we nearly always use a platinum-based chemotherapy with radiation. There are some exceptions to that. In patients who have advanced cancer, where we're treating them with just chemotherapy alone, we commonly use, again, a platinum, but also with a second drug, and that's commonly the 5-fluorouracil. So it really depends on the stage of cancer, what the goals of treatment are, and also on the patient. So giving a patient 2 chemotherapy drugs can be intense, and not everybody's body is able to take that intense therapy. So things can be modified if a patient has certain other medical problems, like heart disease, for example. So all those things are taken into account.
What are the potential benefits of chemotherapy for the head and neck cancer patient, but also what are some of the potential difficulties and side effects and challenges, and what can you do about them if you get them?
So benefits, again, depend on what the goals of treatment are. So in a patient having combination chemotherapy and radiation for a localized cancer, the addition of chemotherapy we think makes the radiation work better. So we know that in trials that have been conducted, that patients that had both therapies together had better outcomes than patients who had radiation alone. So there's some synergy there, okay? In a patient with advanced cancer, we're trying to get some control over the cancer, and in a patient in whom chemotherapy works, we expect that patient to live longer than a patient that doesn't have chemotherapy. The side effects are quite common, okay? They really are quite common.
Could you give them in a little list?
The most common side effect we would see would be fatigue. I would say that that's almost universal, okay? Nausea would be the next most common side effect, but with the improvement of nausea medication, we don't usually get a lot of vomiting, okay? And then beyond that, there are side effects which might be a little bit more specific to the drugs that are used. So common ones would be mouth ulcers and pain in the mouth, low blood counts, and sometimes diarrhea. Okay, and I think the way to manage them effectively is to read any information that your treating team have given you, but also letting the team know if you're getting side effects that are either severe, unexpected, or not responding to any treatments that you may have been told to do. For example, if you're getting nausea and vomiting that is not improving with nausea medication that you've been giving, don't wait. Don't sit at home and suffer. There's nearly always something that we can do to help.
And are there longer term side effects with some of these medications? For example, hearing loss? And if there are longer term side effects, what can you do, if anything, to be ready for them and adapt to them effectively?
So we do get we can get long-term side effects, especially with the use of cisplatin. Now, cisplatin's an interesting drug because it is highly effective, but does have with it some significant long-term side effects. Now, I would say that there is only a minority of patients that go on to develop these in a permanent sense, okay? Now, one way of trying to avoid...
And what are they?
So, hearing loss is one, okay? Tinnitus. So sometimes tinnitus is also associated with hearing loss, but other times it's just more annoying, but the hearing is normal.
And what is tinnitus?
Tinnitus is ringing in the ears, or it's not always a ringing, it's perceived by an unwanted noise, okay? It can be like a whooshing sound or a rushing sound, or that sound you get between radio stations, but a lot of people perceive it as ringing, okay? And that can be mild to severe and can cause distress in a small number of patients. We can also get kidney impairment, okay, and also damage of the nerves in the fingers and toes. And again, those side effects do have a range of being mild to severe. Now, in terms of trying to prepare or avoid those side effects, we do try and prepare patients for that possibility at the time that treatment begins and keep a close eye on those symptoms throughout the course of treatment. And treatment can be modified or even stopped if those side effects are manifesting during treatment. There are patients, however, who get through their treatment fine and then later on down the track develop these. And responding to those is really in a supportive nature. So hearing aids or maskers that can mask that irritating sort of noise, supporting renal function, and also with the peripheral neuropathy or the altered sensation in the fingers and toes, often that does improve with time. So the measures are really supportive.
If someone's watching this and some of these side effects have turned up and it's a few years after treatment at the cancer centre, one issue you hear patients talking about is, do I go back to my cancer doctor or do I go to my GP, my general practitioner? And are general practitioners sufficiently aware of these issues and what to do about them? What would you say?
So I would always say you need to go back to the doctors that you feel you have the best relationship with, and often after an episode of treatment with head and neck cancer, you do have a very close relationship with your oncologist because you've been seeing them every 3 weeks for months and months. So I would say your oncologist is a good place to start. However, there are some GPs who are very skilled in this area and would feel very comfortable helping with those supportive measures. So I don't think there's any right or wrong answer there. There are also certain supportive skilled nurses who might be part of the disciplinary team who also are often well linked into those supportive services.
Just before I go to the innovations that are offering some hope now or in the future with chemotherapy, I wanted to ask you, is there a variation between patients as to how well they respond or tolerate medications. You've mentioned cisplatin, and I remember, correct me if I'm wrong, that before I had it, they put a whole lot of liquid into me through a drip, and then I had to wee into something to prove that my kidneys were working, and I was tremendously excited to produce volumes of urine. But I gathered, I assume they were testing my kidneys. So are there variations in how people tolerate?
So that process that you went through is a process that all patients go through having cisplatin. Because cisplatin can damage the kidneys, we try and essentially flush the kidneys before and after we administer the cisplatin. And that has been shown to protect the kidneys. So to answer your question, yes, there is a difference between how well patients respond. And we see that sort of more immediately in the patients with incurable cancer, where we're giving the chemotherapy to hopefully shrink and control the tumour. And what we know is even with the best chemotherapy agents that we have, only about half of people will have a shrinkage of their tumour. Now, in that other half, what we don't know is why have they not had their tumour shrunk, okay? And what we think it is there is just different people have different types of tumours, and those tumours are susceptible or not susceptible to specific treatments. And what we don't have is a sophisticated way of telling people up front what treatments might best suit them. So that is an area in the field that needs more work, and what would be ideal is if we could do some kind of sophisticated test at diagnosis and say, yes, you need treatment X and Y, but Z's not going to help you. So we're not there yet.
Just before we turn to innovations, it just really strikes me listening to you. I'm a member of a number of patient Facebook sites, as many patients are. They're run by patients, and it's very common for people to ask about particular chemotherapies or other treatments. And really, one person's experience may be extraordinarily different to another. And that's just something to hold in mind if you're a patient?
I think so. I mean, we really don't know ahead of time what is going to happen to any given patient. I mean, I'm sure Amy's had the same experience. You have a patient where you think things are going to go very badly and things go brilliantly well. And then, of course, the reverse is true. So I think what it's up to the patient with their doctor is to decide, one, if they want to go ahead with treatment, and for the doctor to decide what is safe and reasonable, but the rest is really unknown at the start.
Are there any innovations in chemotherapy to mention before we go to immunotherapy?
So the things that are really going on in the chemotherapy space are trying to work out, as I discussed before, whether we can predict which patients are going to benefit from which drugs. So doing work in the lab where we can take a specimen of cancer and grow it in a petri dish and see whether or not we can predict whether a patient will respond to certain drugs, but in a time frame that suits the patient. Now, these methods are already in existence, but they take several months, which clearly does not suit a patient who's waiting for treatment. So can these methods be sped up and be done in, say, a couple of weeks, which would suit a patient? There are also trials looking at how we can protect the ears, particularly from drugs like cisplatin. And I think it's important to mention that one of the advances that has happened in the last couple of years is a significant improvement in our anti-nausea medication. So even when I was going through my training, delivering cisplatin was very difficult because it's a highly nauseating drug. And so the drugs that we have now, it's a single tablet that's taken on the day of treatment, and almost nobody gets nauseated enough to vomit. And people really just do feel a bit sort of yuck for a couple of days, but then it goes very quickly. And that's been a massive improvement even in the last 5 years.
That's fantastic. Look, thank you. And I'll just let people know we're talking to Dr. Venessa Chin, and in a moment, Dr. Amy Prawira, and we're talking about chemotherapy and immunotherapy and clinical trials as part of a series of videos. It's all about innovations in the treatment for head and neck cancer patients. We're trying to survive better and longer, and also have a better quality of life. Look, I want to ask you about immunotherapy, and I went, like any patient often does, to the Cancer Council to have a look at one of their booklets, and they said immunotherapy is a type of cancer treatment which assists the body's immune system to fight cancer. And they said that one of the most widely used immunotherapies is a checkpoint inhibitor, and that some of them are funded by our pharmaceutical benefit scheme, which means, we get them at a very low rate of cost. Can you tell us the names of the main medications as patients would hear about them, and then which of them are available on the pharmaceutical benefit scheme?
For sure. So I'll answer your second question first. One of the immune checkpoint inhibitors or immunotherapy that's currently funded by our PBS or pharmaceutical benefit scheme is nivolumab. The brand name is Opdivo. But in recent months, there has been new updates where another immune checkpoint inhibitor called pembrolizumab, the brand name of which is Keytruda, has been shown to have activity in what we call a first-line treatment setting, or in patients whose disease is incurable but has never had treatment before. Now, these two drugs obviously are drugs of the same class, so as in they should work the same way, but we don't really know whether one is better than the other. Essentially, personally, I do use them in the same way, but there are two options of drugs in the immune checkpoint category for patients with head and neck cancer, and one of them is available on our PBS.
So only one is available on the PBS, and that's Opdivo?
Yes.
Okay, thank you. Could you give me one or two examples of patients, obviously we'll protect their privacy, but of actual patients where you've prescribed Opdivo so that we understand the circumstances in which a patient with head and neck cancer will get access to immunotherapy?
Sure. So I'll talk about that in two scenarios. First are patients who obtain all of their treatment under the PBS or standard of care in Australian standards. And the second is the other way to access immunotherapy at different stages of your treatment through clinical trials. So currently, under PBS, the first-line treatment if a patient is diagnosed with incurable disease is chemotherapy, either one agent or a combination of a few chemotherapy drugs together. And when the cancer, if and when the cancer evolved to become resistant to that, then to go on to have Opdivo or nivolumab as funded by PBS, which is the immunotherapy. So I have prescribed nivolumab under the PBS, coverage in patients whose disease have become clever to chemotherapy.
And is it an option for all head and neck cancer patients whose chemotherapy is no longer being effective, or is it only for certain head and neck cancer patients?
So that's a very good point. So you're right, it is only for certain kinds of head and neck cancer. So the most common type of head and neck cancers occurs within the mouth and within the airways. So in broad terms, these are the cancers in which immunotherapy has shown benefit. But the same kind of cancer, even though they look the same under the microscope, can occur anywhere else. For example, in the sinuses, or sometimes even on the skin. They tend to be treated slightly differently. And immunotherapy is funded, like for skin cancer, it's completely separate, but for head and neck cancers outside of the mouth and the airway as well, it's not funded under the same umbrella.
If I'm currently a patient being treated for head and neck cancer, and I want to see if I can get access to immunotherapy through a clinical trial, what sort of patients would go through a clinical trial, and what would be the benefit for the patient of taking that approach?
Currently, immunotherapy is funded by the PBS in patients whose disease have become clever to chemotherapy. But the new evidence around the world in new clinical trials have shown that there is some benefit to giving immunotherapy earlier on, before the cancer becomes resistant to chemotherapy.
I see. So clinical trials may offer the opportunity to get access to immunotherapy before the chemotherapy starts to fail. So what advantage may there be in getting really early access to it?
So in the recent clinical trial, they showed that if the cancer bears certain markers on their surface, patients might do a bit better when they have immunotherapy earlier on.
So, if you wanted to think of the 2 or 3 most important messages for patients listening to this, because as you know, many patients wonder, will immunotherapy help me? Because there's a bit of media coverage about it. What are the 2 or 3 most important things for patients to remember about immunotherapy right now if they're still in treatment?
So I think when it comes to immunotherapy, there's a lot of hype. Some of it are founded, some of it are unfounded. So it's important to know that immunotherapy doesn't work for everybody. So even though immunotherapy, there's a lot of hype because it has offered hope for a disease where we haven't seen good outcome, haven't seen new treatment with good outcomes for years. So there is some truth in that, but for a lot of our patients, it doesn't work, and we still need to do better. And that's why, a lot of clinical trials are looking at having more treatment or combinations to make sure that it works for more patients, if not the majority or all patients.
I see, so there's hope with immunotherapy, but still a lot more work to be done. Yes. And what work are you doing? Over the next 5 years, because this is a program about innovation, what are the sort of studies that you hope to be involved in and the results you dream of having for your head and neck cancer patients?
So there are studies that we are trying to run within the institution, within the clinical trial setting that I'm running with some of my colleagues here at the Kinghorn and at the Garvan Institute to try to combine treatment to make the immunotherapy work better. And that's what we're trying to get off the ground.
Amy, thank you so much. That was just so helpful. And I want to let you know that if you've got any questions about immunotherapy, you can always get a brochure from Cancer Council Australia or Cancer Council in your state and territory. Or you can ring their information and support line 13 11 20, 13 11 20, and they can send you information, offer you advice and information, and refer you to other people. But it gives me great pleasure to now introduce a second medical oncologist who's also going to talk to us about immunotherapy, because it's a complex topic, and I think it's always good to hear a number of points of view. If I could come to you, Dr. Venessa Chin, how would you describe what immunotherapy is?
So I think immune therapy really invigorates your immune system. We know that in patients with cancer, their immune system isn't functioning normally because it's allowed the cancer to flourish, okay? And so what these immune treatments are doing are kind of ramping up or reinvigorating the immune system so that they can attack the cancer cells.
And why aren't they available early on for everybody if the doctor thinks it's okay?
So at the moment, there is a slight difference between what we know works, but what is available, okay? So as Amy said, what is available free of charge to patients in Australia is access to immune therapy only after chemotherapy has stopped working. Now, in a clinical trial that was reported last year, it was shown that immune therapy earlier on in a patient's treatment, so as the first treatment, either by itself or in combination with chemotherapy, can be of benefit for some patients, okay? That is not yet funded in Australia, okay? So that patients can access immune therapy as their first treatment, but with an out-of-pocket cost.
How significant is that cost?
Very significant. It's around about $6,500 per dose, and that's every 3 weeks.
And do you have patients who are trying to get that money and keep themselves alive?
So I have had a very small number of patients fund it for themselves, yes.
Right. What I'd like to do, if I may, is hear from each of you, what are the innovations or new treatments, novel treatments that are on the horizon?
So I think one of the other things that is happening is whether immune therapy can help people who are undergoing definitive radiation or even surgery to treat their cancer. So at the moment, immune therapy is mainly being used in the incurable setting, but is it helpful for patients having curable or curative treatments? And so there are clinical trials looking at using immune therapy in patients who are having combination chemoradiation, but also around surgery. So that's one area of really interesting research. And an area that interests me particularly is whether we can select those people who are or are not going to benefit from immune therapy. Is there a more sophisticated and reliable way of doing this? The markers that we have at the moment are the best we have, but they don't work very well.
And what proportion of patients who receive immunotherapy, immune therapy now benefit?
So for the listed indication of people having immune therapy after chemotherapy, it's about 20% of patients get a response, meaning that their cancer shrinks. So that's not a very high percentage. Now, in the first line setting, okay, so in people who have immune therapy as their first treatment, it's somewhere between 40 and 47%, I think, off the top of my head. So it's still less than half. And bearing in mind, those patients are selected by a biomarker, so a test that's done on their tumour. Okay, so in those people who have a positive test in their tumour, so that's not everybody, of those people, it's still less than half of people will have a response.
Just before I ask you some final questions, I'm thinking of rural and remote patients. Is it ever possible to have your chemotherapy or your immunotherapy in another location, or do you always have to travel in to the primary cancer centre where you're receiving your treatment, even if that's at a great distance?
I always say to my patients, it's better to go local unless there is something that we can offer you in this tertiary centre that you can't have close to home. A thing that's important to remember is even if your treatment is going really well, you will not feel well all the time. And having long periods of travel can become really difficult really quickly.
And what does tertiary mean?
So tertiary usually refers to a large metropolitan hospital, okay, where we've got access to all the disciplines that are involved in the management of patients with head and neck cancer, like surgeons, medical oncology, radiation oncology, nursing. Now, the rural centres may not have access to all of those disciplines, but they will nearly always have a medical oncologist and also oncology nursing staff that are able to administer medication.
What I want to ask you now is, what are the most common questions that you get from patients? And I'm particularly keen for you to tell me if there's something patients often ask about that I haven't asked you.
I would say the most common question I get asked is, can I have immune therapy? So we've talked about that a lot, and my standard answer is, it doesn't help everybody, okay? And we do all the tests that we've sort of alluded to during this discussion and decide whether or not it's the best first treatment, okay? Also, there are the constraints set by the pharmaceutical benefits scheme here, which we have to acknowledge. If patients are very keen to access immune therapy as a first-line treatment, then I try very hard to find them a clinical trial if that's appropriate for them. I think a lot of people want to know how long they'll live, and that is a really difficult question to answer. And I think it often depends on at what point they are in their journey. Do they have a localized cancer, which they're seeing me for? Do they have a locally advanced cancer or an incurable cancer? But I often try to give a worst case, best case scenario, acknowledging that I am often wrong and that that's just a guide for them.
Yes, because there'll be some people listening to this, watching us today, who are thinking, if it's incurable, why am I getting treated?
So we treat incurable cancers to help people live longer and better, okay? So we know that cancers cause symptoms. They cause pain, they press on things, they make swallowing difficult, and that when chemotherapy works, it shrinks the cancer down and alleviates those symptoms. We also know from the trials that have been conducted before that in patients in whom it works, they do live longer. So it is a personal choice. Not everybody wants to go through it because there are side effects. But in a best case scenario, that's what we're hoping to achieve.
And the key side effects?
The key side effects are the fatigue, nausea, and I think the thing that we need to also mention is the hassle, okay? So patients are spending a lot of time at the hospital, they've got appointments, they've got blood tests, they've got treatment and scans, and often patients aren't willing to go through all of that.
Thank you so much. And Amy, what would be your key messages about immunotherapy? Obviously, people are asking about it. What are the 2 or 3 things you want people watching this to remember?
Because immunotherapy has offered hope in head and neck cancer, where we have not seen new treatment that worked for a long time, for many years. So that is great in that sense, but unfortunately it doesn't work for everybody. And we're trying to constantly find ways so that we have treatment that works hopefully for the majority, if not all of our patients.
Is there anything else I should say to our audience today? We've got clinicians watching as well. What would be your message to members of multidisciplinary teams who've watched us?
I think it's up to us as a community to raise awareness so that we can help patients, but also spark research in this area. I mean, research in head and neck cancer is lagging behind some of the other solid malignancies, and without that research, then nothing ever improves. So whether that be basic science research that we're doing at the Garvan Institute, or whether that's participating in a clinical trial, all those things are needed so that we can improve outcomes for cancer.
Hello, I'm Maureen Jansen from Head and Neck Cancer Support Aotearoa. I'm here to ask a question about immunotherapy. It's Keytruda that is approved but not funded in New Zealand, and a number of people seem to use it as a last resort. They have to use up their life insurance, they have to fund on give a little, and it hardly ever seems to work. But lately I've met a couple of people for whom it has been successful, and I'm asking if there are factors apart from the biomarkers that indicate a successful treatment with Keytruda. Is it something to do with where and how the cancer spread? Is it to do with how well defined the cancer is, or combinations? Thank you.
Maureen, thank you so much for that question. And I also just want to say a special hello to everybody in Aotearoa, New Zealand, who are with head and neck cancer or members of multidisciplinary teams. And thank you so much for joining us for this series of videos. If I could come to you, Venessa, how would you respond to Maureen's question, and also if you could explain terms like biomarkers and so on?
So I guess we can start with the term biomarker. That's really an indication in someone's body, either an indication from their tumour or their blood, that they might benefit from a certain treatment, okay? And we use them across all types of fields in oncology, and they differ depending on the type of cancer we're talking about. But I think the biomarker that she's referring to is a biomarker called tumour proportion score, okay? And we look at the cells in a biopsy and we do a special stain on those cells. And if they stain strongly for this marker, then that has been shown in trials to predict for patients who are more likely to get benefit from immune therapy. It is far from perfect, and that was, I think, what Maureen is alluding to. Are there more specific ways to identify patients who might benefit or not benefit from immune therapy? And the short answer is not really. There are a lot of theories and there is a lot of research going into this, because this is something that's applicable not only to patients with head and neck cancer, but all cancers where we use immune therapy. And really, there are not reliable characteristics in either the patient or the tumour that tell us that someone is going to respond or not respond. So that is the frustrating thing about immune therapy.
And Maureen has clearly known people for whom it hasn't had any benefit, and she's known people it really has. And that's really the pattern we've been discussing in our interview. It must be very difficult for the people in New Zealand when it's not funded by their government as to whether you try to pay for your own Keytruda or not. I mean, it's really like rolling a dice, is it that?
So I think one of the things to keep in mind is that what we're doing is assessing things as we go. Okay, so what I'll often say to people if they decide to pay for Keytruda or any other drug out of pocket is that we'll give a certain number of doses and then reassess, okay? And so that what I often talk to them about is the minimum you're going to spend and then the maximum you're going to spend. And so that you have to be willing to at least spend that minimum amount, but in a best case scenario, if we keep treating, you have to be willing to spend more to stay on that treatment. And I think what's important to note is even if you're on a treatment that's working, if you can't afford to pay it, then we can't give you the drug. So we don't have any sort of special powers in that sense to give people drugs that they can't afford to pay for. So it's an interesting part of medicine and an interesting part of oncology talking about financial toxicities of drugs. And it's a really difficult area, and it can be very difficult for patients. So I often say to people, if you can do this without remortgaging the house, then we can consider it. But if you're looking at going into serious debt to pay for a drug, I don't support that. I don't think that helps anybody.
Would you deny it to someone if they chose to mortgage their house?
I would never deny them, but I would seriously get them to reconsider. I have had a few people that have gotten into strife, and it is not a good situation to be in.
Well, look, I'd like to say to both of you on behalf of everybody, thank you for giving us this time today here at the Kinghorn Cancer Centre. I've been talking to Dr. Venessa Chin and Dr. Amy Prawira. We're in the Kinghorn Cancer Centre. This series of videos on innovations in treatment for head and neck cancer is hosted by St Vincent's Hospital Sydney and the Kinghorn Cancer Centre. I'm Julie McCrossin. Thank you so much for watching. And remember, if you have any questions or you'd like to talk to somebody, if you're in Australia, ring Cancer Council information and support line 13 11 20. 13 11 20. There are clinicians on the end and they're friendly and they are very helpful. And also there is a website that's all about head and neck cancer that will be of value anywhere in the world. It's called beyond5.org.au. And whatever screen you're watching this on, we'll have that written down. Thank you.
Head and neck cancer, treatment innovations, improving survival and quality of life. Providing up-to-date, evidence-based information for everyone in the head and neck cancer community. Presented by Julie McCrossin, a head and neck cancer survivor. Media production by Daniel Taylor at Insight IT. Celebrating World Head and Neck Cancer Day, 27th of July, 2020. Innovations in surgery, radiation therapy, chemotherapy, immunotherapy, dental care, managing distress and recovery, managing mask anxiety, remove the mask research, Aboriginal and Torres Strait Islander patients, family and community. Discussions of innovations that are improving survival and quality of life for patients with head and neck cancers. The 2020 Head and Neck Cancer video series. Presented by St Vincent's Hospital Sydney, the Kinghorn Cancer Centre and St Vincent's Private Hospital Sydney.